welcome to the Freezing of Gaits webinar. I'm Casey Peluso of Parkinson Foundation, Western Pennsylvania, joined by Rory Bueller of Parkinson Foundation, Western Pennsylvania. He's a Master of Social Work intern, and we're delighted to have Sidney Collin and Ron Blehm return. They conducted a webinar for us over a year ago, and freezing of gait is a problematic issue, and they're going to be talking about some of the practices that can help. Okay, so Sidney Collin is the founder and the inventor of NexStride. She's also the co-founder and CEO of Auditory Devices, which is a medical startup. His mission is to develop products to improve mobility, independence, and quality of life for people like you. And we're also joined by Ron Blehm, who has been a physical therapist for over 30 years and a clinical instructor and very knowledgeable about the topic of freezing of gait, amongst other topics regarding Parkinson's. Thank you both, and let Sidney and Ron take it away.
All right, welcome everybody. Happy Tuesday and kind of the later half of February. I'm going to share my screen here. Let me know if y'all are able to see it. I will go to full screen mode here. Maybe. There we go. Does that work for everyone? I'm getting a couple of thumbs up. So, all right, cool. All right, so I am here representing my LLC, which is EEI Physio. My name is Ron. A little quick introduction about me. Before I became a physiotherapist, I was a firefighter EMT. As Casey mentioned, I have been a physical therapist for a while, including some work with Parkinson's patients as well as others. My father-in-law actually had a form of Parkinson. He was managed at home for nearly a dozen years. I was also privileged to be able to co-author a couple of research studies on Parkinson's, including the benefits of exercise and some agility exercise to help with the symptoms of Parkinson's. As an aside, well, yeah, I do some Tai Chi and Qigong instruction as well. Currently, I'm working in primary care. And that's kind of about me. So this talk has been updated since we presented here just over a year and a half ago. So hopefully if there are any returning participants, it'll be different enough or a good review. So when you look in the textbook about freezing of gait, it basically describes a sudden freezing or stopping of motion, which makes it difficult to step or to continue walking. Freezing of gait, not always, but often is associated with disease progression, and it can be worse when you're changing environments, going around corners, walking through doorways, or in some stressful situations. I have some videos coming up here which can be a little bit difficult to watch. Hopefully, I don't make anyone uncomfortable for the sake of demonstrating what we're talking about. These are maybe some more of the advanced or pronounced cases. And as always with exercise, the sooner we start and the earlier we can start taking steps to prevent progression, the better off we are for the long time. Freezing of gait is more commonly associated with disease subtypes that feature slowness or postural instabilities, and it is less commonly seen in those tremor dominant types of Parkinson's subtypes. Freezing of gait in and of itself is it's a symptom. It's not necessarily related to your dopamine levels. Therefore, it's often less responsive to the medications. So if they start you on L-Dopa or some of the other related medications, oftentimes the freezing of gait aspects do not necessarily improve. Because it's more difficult to treat, and those patients are less likely to put themselves out there because of the symptoms being worse. It is much more common for patients with the freezing of gait subtype to be more isolated, and that in and of itself is a concern for well-being, which is why support groups such as Casey's group here are phenomenal and fantastic. And Sidney and I wish that there were many, many more groups with more participants across the country. Really, in my profession, I am kind of a falls expert. So I work well with people who are at risk for falling down. Since patients with Parkinson's tend to fall down about twice as often as their age-matched counterparts, falls is a logical connection to work with Parkinson's, which is a logical connection to implement some of the other fall prevention techniques. Not only do patients with Parkinson's fall down more, those specifically that have freezing of gait fall down 4 times more than other patients with Parkinson's. That would be 8 times more often than age-matched peers. And importantly, they are 6 times more likely to have injuries from falls. So preventing these things, finding tools and techniques to help overcome the freezing episodes are huge. I have a couple little simplified pictures and graphics here to show you. So let's take a pretend patient. We'll call him Bob. And we put Bob on a computer force plate and ask him to take a step forward. And kind of the way the tracing looks on the force plate is there's an initial shift to the right side, and then a larger weight shift to the left side, and then an acceleration forward onto the right step. So that's how a normal step would look for any individual of any age. We ask new Bob to take a step with his right foot. This Bob may have a type of Parkinson's sub-feature that makes him retropulsive, makes him tend to tip over backwards, harder to get up out of the chair. When we ask this patient to take a step forward, again, we see the initial little shift to the right side, but then his momentum is going backwards and he's unable to recover and he keeps tipping back. The third Bob in this demonstration may be an individual that has freezing of gait. And when we ask this person to take a step forward with his right foot, again, there's that initial little shift to the right, but then he can never adequately get to the left. And then we see this jittering, shuffling back and forth without any effective step. And that's kind of how freezing of gait would look on the computer force plate. Parkinson's disease is kind of interesting because of physiologically how it works in the brain. Oftentimes, the higher, more cognitive brain can overcome some of the effects of Parkinson's. So, for example, take a patient with resting tremor, and it's called a resting tremor because it happens when he's doing other things. If he concentrates, he can make the tremor stop. And in fact, one of compatriot of Dr. Parkinson's wrote a follow-up paper that suggested that this shaking palsy that Dr. Parkinson described was little more than a paralysis of the will, because if you ask a patient to take a giant step or to stop tremoring or whatever, they can do it for a very short period of time. That was in the 1800s. Over the last 200 years, we've learned some things, and we know that this is not actually the case now. I like this simplified analogy of the cockpit of a large airplane. This is like your brain that controls what you do and how you move. And right in the middle of the cockpit is the autopilot. That would be like the basal ganglia in the brain. The autopilot takes care of some of the automatic flying things so that the pilots can pay attention to their navigation and their fuel flow and talking to the air traffic controllers and making sure all the systems work and let the plane fly itself. Similarly, the basal ganglia in our brains take care of some of these automatic things that we would normally do, like what size step you take. That has been programmed in from youth and childhood and continues to be automatic in most cases. However, Parkinson's specifically targets these basal ganglia structures and causes them to short circuit. And over time, it's like taking away more and more and more of the autopilot. Parkinson's in and of itself isn't a fatal disease. And freezing of gait in and of itself isn't necessarily something that we specifically treat. However, you can see if the pilots have to fly the airplane and monitor the fuel and take care of the electronics and talk to air traffic controller and monitor all of the navigation, it can become too much. And that's what we see in patients who suffer from Parkinson's and freezing of gait, is all of these inputs just crowding in. The basal ganglia isn't able to keep up, and their higher brain can overpower some of these aspects, but eventually it just becomes too much. When we talk about something automatic like balance and walking, there are a lot of things, and I'm not going to go into deep scientific research, but this list on the left side here are all of the things, well, not all, many of the components of balance and walking. And it's a lot to keep track of. About halfway down the list there is something called anticipation or metering. This is your brain's ability to know how big a step is. And you're walking across the street, you come to the curb, you step up. Metering is programmed in so you know how high to step. If that part short circuits or you're distracted by the crosswalk counting down or the horns honking or the bus coming, and you may pick your foot up, but you don't clear the curb and you trip and catch your toes, that's because your metering, your basal ganglia, is a little bit overwhelmed. In this research study by Doctors Peterson and Horak, it was noted that especially walking and stepping were components of mobility that were especially difficult or targeted in patients who suffer from freezing of gait. Rehabilitation strategies to focus on these stepping and anticipatory moves are most effective. Another example from that computer-generated force plate that we had our pretend patient Bob standing on. In this case, we had Bob stand on the force plate and we asked him to shift his weight side to side in rhythmic shifting at slow speed and also faster speed. We also had him shift his weight frontwards and backwards on the force plate to see how he moved and how his control was. At our first visit, you see across the bottom here, all of his scores were in red. His speed was not matching the metronome. His accuracy was not matching the targets. His control, it's close to the line, but wasn't within the red. And we see as we asked him to go faster and faster and faster, his control got worse and worse. After 6 months of physical therapy, working on skills like Tai Chi and stepping and weight shifting, we see that his scores are much more green, his control and his timing and his speed much improved, especially on that top graphic of side to side at high speed. That's much better for this patient. And that is one of the benefits of therapy, and especially targeted exercise therapy. Another analogy that I like to show for patients, here on the right side of the picture, we have an X. That's you sitting in the chair in your living room, hanging out, having a good day. And suddenly the doorbell rings and you're wondering, who could that be? Well, in order to get from your chair to the door, many things need to happen. You need to stand up, you need to get your balance, you need to feel well. My physical therapist said that I should take my time. Maybe my balance is a little bit off. Maybe I need to get the cane, but I feel like it's taking so slow. Who could be at the door? What's going on? I need to step around the table. I feel like I'm shuffling. Don't hit your head on the lamp. Watch out for the table, look out for the change where the carpet turns to flooring. All of these things quickly overpower the basal ganglia, and it becomes too much, and the patient has difficulty getting to the door. Then the doorbell rings again, and they feel like it's just overwhelming them. Basically, here is what happens. And thank you, Sidney, for this picture. I love this graphic, it's fantastic. So we're trying to get to the door, and there's all these things going on, and it feels like the message that you're sending to your feet are just short-circuiting and just isn't making a connection. So what we look to do through therapy is to develop and hardwire some new connections, like the picture on the right, where we can bypass some of the old habitual movements and the old habitual forms and bypass or retrain that basal ganglia. Yes, you can retrain these parts to work better and work more efficiently. Here's one of these videos I will show you about a patient who struggles with these things. Walking, surface change, turning around. It looks like he's hovering, just very difficult to do that. Through the doorway, barely picking up his feet. Difficult for the patient to maintain his balance and try and move at the same time. This is from a video, and I don't have sound with this one, but basically I will read along with it because it goes pretty quick. We mentioned a research study earlier by Doctors Peterson and Horak talking about the importance of targeting, stepping, and gait and walking. This is that Dr. Horak in an interview talking about 3 ways that therapy is really helpful for patients who suffer with Parkinson's. So there's compensation. Exercises can help you compensate by finding new ways to move and new tricks to get around some of these difficult things. Working with a therapist or trainer, the brain can learn new pathways to move. Here I am working with, let's call him Bob, on some Tai Chi. Exercise actually changes the brain. Whereas we used to be taught that you were born with X number of brain cells that only die off as you get older, that's not true. We can train the basal ganglia. We can learn new ways to move. The brain does change with exercise. The brain grows with exercise. And in fact, there is strong evidence now that exercise can be neuroprotective. And this is why in my work in primary care, I am all about starting these things earlier in life. And I lost my Jersey. Earlier in life. And it's easier to keep something, to keep a skill, than to relearn a skill that you had previously. So rehab and therapy. What we are looking to do is using exercise to restore or preserve the mobility that you have. Like Dr. Horak was talking about, compensation, learning new ways to move or learning shortcuts that make the movement easier. This is something that we'll talk about in more depth here as we go. Or adaptations, using the neuroplasticity and again, tools or modifying your environment. In the picture earlier with the 2 coffee tables and the lamp and the chair, maybe having a little less furniture would make it easier to answer the door and get the Amazon package. So therapy exercises improves your fitness, and better fitness has many benefits, even for patients that have Parkinson's, such as improving your posture, increasing your strength or your range of motion, training specifically to be able to do multiple things or rapid task switching without that cognitive exhaustion that is so common. Improving mental agility and attending to tasks on hand. We'll have some research about attending coming up here shortly. Improving your sequencing and prioritizing of tasks, improved coordination and reaction time. All of these things are improved through regular daily exercise and activity. There are a number of exercise proposals or exercise umbrellas that work well. Speed training, multitask training, exaggerated motion, like is shown in the picture here, sports specific training, forced balance, challenging training, etc. The research study that I was involved in included kind of a combination of high intensity circuit training, and we did 10 minutes of each of a different kind of category of exercise to target some of those important areas like aerobics and strength and coordination. Compensation, modifying your environment, having a clear pathway. So in that example given, we don't have to walk around the coffee table or change surfaces. Providing targets and only attending to one target at a time. Adding grab bars, railings, or cueing devices can be hugely important for compensatory skills. I don't know if any of the patients have had a therapist that put duct tape on the floor, but these visual cues, these targets can make it easier. Rather than walking across the room 30 feet to the door, you only have to attend one target at a time. So the way that looks visually is, this is the same gentleman we saw before, much better walking, clear steps, no change walking across the carpet. We have a metronome that's clicking, and with the click, he can move his feet and turn around in rhythm with the metronome. So visual cues or auditory cues can be hugely helpful for patients that have freezing of gait. While physical therapy and exercise treatments can be helpful, I found 92 recent studies about adding visual or auditory cues to the exercise programs like we just saw in that prior video. So this study from 2016, they looked at using a laser device, and what we saw is with laser, the episodes of freezing were a quarter what they were with nothing, and with sound, they were half as much. So some really good benefits from these types of cueing devices. Visual and auditory cueing on the treadmill were probably more effective than other types of exercise or implements to compensate while walking. Visual and auditory cues improve gait, but they do so in different ways. So it's different parts of the brain. Someone who responds to the visual cue may not respond to the auditory cue. Some people may need both. It's difficult in therapy when we only have access to one of the cueing devices. It would be nice if something existed that could do both. This research study looked specifically at doing both, and they assessed the step as well as the walking speed, as well as the number of freezing episodes. And they noticed that there were benefits with visual and auditory cueing because cues help patients to bypass defective basal ganglia circuits, like that short circuit little video clip we showed before. Both auditory and visual cueing were effective for motor movements as well as gait in patients with stroke. So these types of tricks, not only for patients with Parkinson's, but patients who have suffered a stroke, or even I have used these similar things on orthopedic cases as well. Cues may reduce attentional demands. The colleague of Dr. Parkinson that said, if you just think hard enough, you can overcome these things. Well, thinking really hard and concentrating very carefully is exhausting. So oftentimes being able to have a helpful device can reduce attentional demands and reduce exhaustion. We had talked about adaptation as well, adding assistive devices like walkers or canes, teaching caregivers to provide increased assistance, patients not left alone. I was involved last year on an NIH grant looking at falls in patients with dementia. And one of the huge aspects to consider are the caregivers and caregiver burden, and how available, how much training do caregivers need to be able to help patients adapt to their environment. And then also modifying expectations, like allowing more time for rest breaks and pacing. So some high points for therapy is to improve mobility and strength. We may also offer tools such as canes and walkers and railings to help patients get around, or adapt with devices that actually can provide cueing to allow you to interact within your environment a little bit better. These tools and these devices and these exercise all really only have one goal, and that goal is to allow the patient more freedom and more independence and more safety to be able to do the meaningful things in life that they actually want to do. There are a number of effective therapy and exercise programs. These have been widely published and highly researched. Exercise approaches to minimize the effects of Parkinson's disease have been shown to be neuroprotective and are highly encouraged. And while there is no device that can replace exercise and high quality therapy, it seems very reasonable that using devices in conjunction with your activity, in conjunction with your exercises, while you're engaging in your environment, allowing patients more freedom and more safety and more independence. This is absolutely the way to go, and what I highly recommend my patients use. So any specific questions for me, or we can circle back at the end, because I think there are some devices available which may be pretty interesting.
I don't see any questions in the chat, Ron, so I'll go ahead and share my screen and I'll give you all a little bit more information about freezing of gait specifically and the solution that I created to help people with freezing of gait. But start to think about, my section will be pretty quick, so start to think about any questions that you all have for either Ron or I to share. Okay, so I'm going to talk a little bit more about freezing of gait. As Casey mentioned, my background is in biomedical engineering, so I'm not a physical therapist, but I did do a lot of research in understanding how the brain works and how the brain affects the body. That connection has always been really fascinating to me. So Ron talked about this a little bit, right? What's freezing of gait? What is it? What can we do about it? So freezing of gait is unpredictable. It is medically defined as a sudden onset of immobility, but people will describe it as feeling like their feet are glued to the floor or stuck in a box of cement. So no matter how hard they try, they can't pick up their foot. This can happen suddenly. It can happen when you're initiating gait. It can happen when you're walking into a doorway. Initiating gait just means when you start walking, like you get up from a chair and you're taking that first step. That's gait initiation. So a lot of times people will feel stuck then. You'll feel stuck if you're walking through a doorway, if you're walking into an elevator. These are all common triggers for freezing of gait. It's a major risk of falls, especially for people with Parkinson's, right? It's one of the highest reasons for falls for people with Parkinson's. And that can in turn affect the fear of falling. So if you know that you freeze, you might be scared to walk, you might have that fear of falling, and that will then affect your exercise level. It'll affect your independence, it'll affect your quality of life. So as Ron was saying, exercise is super important for everybody, but it's especially important for people with Parkinson's. Exercise is the only thing that has been shown to slow the progression of Parkinson's disease. Medication can help with symptoms. There are other things that we can do to help, but exercise is the only thing that has been shown in research to slow the progression of the disease. So super, super important. And as you all know, right, if you're falling more, so freezing of gait leads to increased falls. If you're falling more, then you're scared of falling. If you're scared of falling, then you're not walking as much. If you're not walking as much, then you're not getting as much exercise. And it just perpetuates, it creates the cycle that just kind of gets worse and worse and worse. You become more and more immobile, and then your symptoms get worse. So again, this isn't supposed to be depressing. There's I'm trying to reiterate the point that exercise is really important for all parts of your life, right? Not just specifically for walking. We mentioned some of these common locations triggers, so narrow places, doorways. A lot of people will freeze when they're turning, when you're initiating a step. So let's say you get out of a chair, you're taking that first step. A lot of people freeze right at that moment. Freezing can happen just for a couple seconds. It can also happen for minutes at a time. So there's a huge range in how people experience this. And before you completely freeze, there's also a little bit of shuffling that can happen. That is also under the classification of freezing of gait. There are also emotional triggers. So I had somebody that I used to work with that would freeze every time someone would tell them to hurry up. So let's say she's like crossing a street and her granddaughter would say, "Come on, hurry up." Let's call her Jill. "Come on, Jill, hurry up. Like, get across the street before the cars come." And she would immediately freeze, right? It's that anxiety of, it's that fear of, I have to keep going, that would cause her to freeze. So here's one example of what freezing of gait can look like. This is a man named Jack Brill, who I met a long time ago, and the person who I actually made this device for originally. So this is him freezing, right? You can see his legs are trembling. He's trying to pick up his foot. No matter how hard he tries, he can't pick up that foot. As Ron mentioned, the reason that this is happening is because of that disconnect in the brain, right? His brain is sending that signal to say, okay, foot, time to take a step, but that signal gets lost. It doesn't get to the muscles that are activating his foot to take that step. But what we've learned is that we can use these visual and auditory cues, as Ron mentioned, these external cues, to activate the goal-oriented part of the brain instead of the automatic part of the brain. And that allows you to, bypass that damaged part of the brain and allow someone to be able to restore mobility. So you are initiating the same movement with a different part of the brain. There's all sorts of research behind this, right? As Ron mentioned, he found 92 studies that have been published showing the efficacy of these visual and auditory cues. It's also standard of practice in physical therapy clinics to treat freezing of gait. As Ron mentioned, the parallel lines of tape on the ground, that's very common. You'll also see like marching music, you'll see metronomes. A lot of times PTs will clap to the beat of a metronome. So those are all visual and auditory cues. All I did was take the most effective visual and auditory cues and put it into a small portable device that can attach onto any cane walker or walking pole. So what that does is it takes these cues that are already being used in the physical therapy clinic and it makes it accessible to people anywhere. So for Jack, for example, he knew that these visual and auditory cues worked because he used them with his PT in his physical therapy courses. But when he went home, he couldn't go to the bathroom by himself. He couldn't go on a walk with his wife, Sandy. He didn't feel confident enough to be able to walk on his own. So, I made this device for Jack, right? Took the most effective cues, put them in a small device that attaches onto any cane, walker, or walking pole, and allows people to be able to restore mobility or prevent freezing of gait from coming on in the first place. So the visual cue that we use is a green laser line projected onto the floor in front of you. The auditory cue is a metronome. So you visualize yourself stepping over that green laser line. You try and step to the beat of the metronome. And that change of intention changes the part of the brain that's being activated and it allows someone to be able to start walking again. Here's a video of Jack walking with our device for the first time. So for Jack, it's quite an immediate change. Here's another video of someone who's actually experiencing a freezing episode. He's unable to move his legs until he activates that green laser line with his thumb, and then he's able to start taking those first steps. So these are two different ways that someone can use it, right? So Jack is using it continuously. He has a laser light on every time he's walking, and that prevents freezing from coming on. And then Trevor here is using it on demand. So he'll freeze, he'll turn on the laser light, he'll start walking, he'll turn it off, and he'll keep walking. As we mentioned, lots of research behind this, most notably in Parkinson's disease, showing a 40% reduction in falls, 43% reduction in the frequency, so the number of freezing episodes that come on, and then 69% reduction in the duration of freezing of gait episodes. So people are able to get out of those freezing episodes faster with the use of these visual and auditory cues. There's also plenty of research behind stroke and cerebral palsy and all sorts of other neurodisorders who can use this, but that's less relevant to this conversation. One of the most important things that I want to get across here is even though there's all sorts of research behind the efficacy, that doesn't necessarily mean that people are going to like it and enjoy using it. So what we did is we just took a survey of, these are all people with Parkinson's who use the NexStride for over a month. 93% of people report increased confidence while walking. 86% of people report increased general mobility, so being able to get up and move around a little bit easier, and 75% of people reported decreased fear of falling. That is our goal, right? Is to take away that fear of falling and increase independence for people using this tool. Okay, so I'm just going to show you a quick picture of the device attached onto a cane, attached onto a walker, attached onto a walking pole, so you can get the visual that it attaches onto anything, any cane or walker. Here's a great picture of one of our customers, Walter. He takes this device everywhere. So this is him in Vegas. And then this is a picture of him on a hike with his walking poles and with the NexStride. So he's a big hunter, he's hiking, he's a very outdoorsy, active guy, and he brings his NexStride everywhere to reduce freezing and reduce falls for him. Something that is important to note here is that NexStride is one option for freezing of gait, right? There's, as Ron mentioned, your physical therapist can help you with like internal cueing is another option, right? You don't necessarily need external cues, but they can help if you don't want to remember what the physical therapist told you 3 weeks ago to do when you froze. There are some deep brain stimulation that will help with freezing, not across the board, but there's some new research that's showing that a lower frequency of deep brain stimulation might help people who have freezing of gait. So I want to make sure I'm giving you information about the product that I created, but I want to make sure you know that there are other options out there as well. Like the U-Step walker is a great example, right? They have a walker that has visual and auditory cues integrated into it. our device has the visual and auditory cues attachable onto anything. So it's not only in that walker. And then just some quick information about pricing for us. So our price is $499, about $500. You do have $50 off through the Parkinson's Foundation of Western Pennsylvania. Here's that discount code. And then we have payment plans, and it's also covered for veterans through the VA. It's covered by the Parkinson's Wellness Fund. You can get a grant through the Parkinson's Wellness Fund to cover. We will work with you on this. If you have any questions about whether this might be a good fit for you, whether you're interested in it, just reach out to me and I'm happy to help you. You know, cost really shouldn't be a barrier to get NexStride. We have all sorts of resources to help people cover the cost and make sure they can try it out. We also have a 30-day money-back guarantee, so you can try it, see if it works for you. If it's not a good fit, send it back. We'll pay for shipping both ways. That way people can test it out. Okay, so I'll stop here and take a look at the chat and see if we have any questions. Okay.
There was a chat up there, more likely linked directly to you, and then I am responding to a couple of these that we can also chat about. I guess at any point in time when Casey is ready.
So I see one. I can just go ahead and jump in, Casey, unless you want to.
Yes, please go ahead.
Okay, cool. So it looks like somebody asked, what if someone doesn't use a walking device? Can it be attached to a belt or anything on the person? Great question. We are actively working on a device that attaches onto the belt. You know, there are physical therapists are very handy, you know, are very creative. So there are physical therapists that have put it on a gait belt and like attached it onto the person somehow. The device we currently have is not built for that. It's really built to be attached onto a cane or a walker. But we have a device that's coming out probably in a year. Hopefully, if all goes well, that will attach onto the person, and it'll also include vibration, which is another cue that can help people. So Jackie, if you want to be on that list to get an email when that device is ready, just send me your email, or I'll put my email in here, or you can just put it in the chat and I'll add you to that list. Okay, it looks like, Ron, you might have already answered this, but I'm going to ask this question for everybody else's sake here. We had a question saying, when it was mentioned that the brain can be retrained, does the word neuroplasticity fit in there somewhere? If yes, please describe neuroplasticity.
So when we break that word into its part, neuro means brainy stuff, and plasticity means like Play-Doh that is pliable and movable. So the brain is pliable and movable and can learn new things. Quick, easy example, someone has a stroke and initially cannot speak. Get them into the ER, give them the clot buster, whatever, and their weakness and ability to speak returns. The brain is very good at these adaptations and compensations and can learn new ways to move. In the case of Parkinson's disease, since it goes after the basal ganglia and the autopilot, it takes a lot of brain power to compensate and learn these new things. That's why some of the research studies last a year or more, is getting patients to do these things in repetition to learn a new way to walk and a new way to move. Imagine some kid that has played basketball his whole life and goes to college and joins a team on the NCAA, and they start over with how to shoot a hoop and how you have to make your wrist go and follow through it. All these things the kid never did before. It takes a long time to learn these skills. And yes, the brain can learn new ways to compensate and new ways to move. The brain is very plastic and very adaptable, but it's hard work and it's exhausting. So if there were a device that helped to give you finite cues or targets or some external mechanism to allow your movement to be better, then you can learn these skills faster. And that's what Sidney's talking about, is an external device to provide additional coaching to help the skills to be learned more quickly.
Yeah, and Brandon also asked about or made a comment about the Gait Better program. So I know the people at Gait Better. I think they're fantastic. I love what they do. So what Gait Better does is it's a in physical therapy treatment, and it uses kind of similar visual and auditory cues as what we use, but it's used as a therapy in the physical therapy clinic. So can definitely be super impactful. I think they do a great job. I think they have some great research showing the fall risk reduction that they can show in it, like with a physical therapist. The difference between our program and Gait Better, I actually think that they're really complementary, because they do something that's used in physical therapy, and we have something that you can then take out of physical therapy and keep practicing what you learned with the Gait Better program.
See, for years and years and years, therapists thought that they were awesome because they could do all kinds of amazing things in the clinic, but then it's hard to replicate those things at home. It's hard to remember exactly what the therapist did. What did they say? What was the thing? And then Sidney comes along and makes a thing that you can take home with you, which is awesome. So, and it's the same thing, you know, someone had asked about like a Wii platform or similar kinds of force plate things. I had a couple graphics up there about Bob on the force plate, and that is great for scientific research and to learn how we move, but those things don't go with you, and some of them cost $500,000, and we don't have that kind of money. And while it's good to practice that, while it's good to have therapy for that, what is needed is a device that's portable that can go with you and attach to if you need an assistive device that can go with you. And that's kind of the beauty of this particular thing.
There also something I would recommend is there's an organization here in Austin called Power for Parkinson's, and they do all sorts of free Parkinson specific exercise classes. You can just go on YouTube, type in Power for Parkinson's, and you'll see all sorts of free classes that might be helpful for people. And then Karen also mentioned that PATF could help with the cost. Yeah, so actually every state has a technology center that can help both like get you a demo of the product if you want to try it out first. They can also help with the cost of the product. So this is the Pennsylvania Assistive Technology Foundation. And she put the link in there. So feel free to reach out to them. They might be able to help. Sharon was on here. I don't know if she's still here. Said that she uses NexStride and has found it helpful. So thanks, Sharon. I'm glad someone's using it.
Sharon also asked about internal cueing. So those are cues that are self-generated. They come from the patient. They come from you. And they can be really effective. They can also be tiring. You also have to remember to do the cue. So some of the therapy things like exaggerated motions that we talked about, I'm going to scoot my chair back here. So some of the therapies that we talked about are really, really dynamic, and they have you jump to your feet and do really dynamic things, which is great for training. But then when you're at home eating ice cream and the doorbell rings, you have to remember, oh, that's right, I need to stand up like that. And it's hard to do as part of your normal daily life. So internal cueing is important. Internal cueing, reminding yourself, you know, make it to the next crack in the sidewalk, make it to the next light post, take big steps. All of these things are useful and helpful. And it plays into habituation and neuroplasticity, but they can be exhausting. And so supplementing your internal cue with an external cue can be just that. One of the things that's great, and Sidney had a video of the guy, did you say his name was Eric? Walking along and he's doing fine. Then he freezes. Then he can turn the machine on and keep going, kind of thing. So he has his internal cues that work fine until they don't. And then he has an external cue that can help to get him over that one little part.
I also put our website, email, the discount code, and our phone number in the chat for anybody who wants that.
Does anyone have any additional questions? I have a question. Have you considered any type of insurance reimbursement for this product? No, I think you're mute.
We've been working on that for a long time. Unfortunately, it just takes a while to get there, but we are doing some pilots with some big insurance companies right now. So fingers crossed that will be covered soon.
Thank you. Any last questions? Well, I'd like to thank you, Sidney and Ron. This was very informative, and if you'd like to check out NexStride, certainly visit their website. And I also have information through the Parkinson Foundation Western PA.
All right. Thank you, everybody. Have a
Thank
good
you
one.
for
Thanks for
attending.
having us, Casey.
You're welcome. Thank you, everybody.
Hi, thank you.